Greetings everyone, I am Kritika Saxena, I am a clinical psychologist and today we are here to discuss more about anxiety disorders. Anxiety in our common language, what do we understand by it? Anxiety is this feeling of discomfort, unease, distress which is not there on an everyday level. You're going about your day, doing your academic responsibilities or your occupational responsibilities, and everything that was planned or is in order, is meeting the structure that you had, is going as per the plan, is organized. That is something which would not cause anxiety because nothing is out of order. Anxiety is the feeling of distress or discomfort which comes with something which is unanticipated, unexpected, and also sometimes where we are preemptively anticipating that something might go wrong. So, to further define it, it's a complex blend of unpleasant emotions and cognitions. It is both oriented to the future and much more diffuse than fear. That's what Barlow stated in 2002. Now, what is fear? Fear is the source of danger which is obvious, which is an experienced emotion, and that's called fear. Now, there can be fear of snakes, rabbits, rats, different animals too. There can also be a fear of heights. But in that case, what would you do is that you will only step away from the fear. Anxiety, whereas anxiety can have more frequency, more specific in terms of danger, which can be, let's say, about health anxiety or the anxiety about your parents' health. So, along with cognitive and subjective components of anxiety, there are also physiological and behavior components. Let's understand what are those. At a cognitive level, the negative mood or worry about possible future threat or danger. At a physiological level, which is on a more bodily level, it creates a state of tension or chronic arousal. At a behavioral level, it may create a strong tendency to avoid situations where danger might be present. Certain facts and figures about anxiety. Anxiety disorders impact approximately 18% of the population. That was a study which was done by NIMH in 2013. Anxiety disorders have a lifetime prevalence of approximately 30%. And close to 50% of individuals diagnosed with anxiety disorder may also meet the criteria of a depressive disorder. That is called comorbidity, that two disorders coexist at the same time. Coming to etiology or the causal factors for anxiety, there is a genetic cause wherein our limbic system, it's a part of our nervous system. It is often known as the emotional brain. And here the neurotransmitters such as GABA, norepinephrine and serotonin come into imbalance which create the state of anxiety. On a behavioral level, the causes are that individuals who have perceptions of lack of control over their environment or their emotions. A sociocultural background may also play a role in what people are afraid of or become anxious about. Parenting styles may also influence the likelihood of children developing phobias, fears, and other anxiety disorders. So, just to summarize that, the causal factors are that of genetics, of neurobiochemical level, of psychological, of socio-cultural level, of parenting. Now, there are different types of anxieties as defined by DSM-5. DSM is the Diagnostic and Statistical Manual, which gives us the criteria for all the mental health disorders. In that, it specifies there is panic disorder, agoraphobia, specific phobia, social anxiety disorder, separation anxiety, selective mutism, and generalized anxiety disorder, also known as GAD. The anxiety disorder due to any other medical condition, that is also accounted as anxiety. The substance or medication induced anxiety is also something which is noteworthy. And sometimes there are other unspecified anxiety disorders as well. Those are all your anxiety disorders and its types. Starting with what is separation anxiety? Separation anxiety is an inappropriate, excessive fear or anxiety concerning separation from a significant individual or to whom we are attached. Now, this is a recurrent distress and anticipation that is experienced in terms of separation from home or from that attachment figure. A persistent and excessive worry about losing that major attachment figure and possible harm that could happen to that individual. Excessive worry about experiencing untoward event that causes separation from the attachment figure, and a persistent reluctance or refusal to go out or go out without their company. Separation anxiety disorder can also be seen as persistent, which is excessive. There is a reluctance to sleep away from home or from the attachment figure. There are repeated nightmares involving the theme of separation and repeated complaints of physical symptoms. Now, whenever we are taking case history, the points that we must remember are that of emotional temper tantrums. Your questions as a clinician when you are trying to rule out a diagnosis can be, how is your mood? How do you often feel anxiety? Or for eliciting physical symptoms in the child, because especially children have separation anxiety, can be increased heart rate, palpitations, excessive sweating. So, to elicit that, what you can ask are there any physical symptoms that you experience with anxiety? Is there any bodily discomfort that you feel? You should also ask if he or she is unwilling to do any activities separately from the attachment figure. There can also be refusal to sleep alone, nightmares. The question that here you can ask are you able to sleep by yourself? Another few points that you can ask are that, is there too much clinging behavior with the parents or the significant caregiver? Are you able to go out? Are you able to go to school? Are you able to go to park? Are you able to carry out your play activities? If there is any significant deterioration in the school performance of the child, and that is something that you can ask both the parents and the teachers, if the child is unable to concentrate in the studies which is happening due to anxiety. There can be recent triggers also, which can be emotional or physical, and you can ask, is this a recent change that has happened or that you have noticed? If yes, then what can be the triggers that we can identify that may have caused the behavior. That is all for your separation anxiety. Moving on to selective mutism. Selective mutism is a consistent failure to speak in specific social situations where there is an expectation of speaking. It could be school, it could be a conference, and this is despite speaking in other situations. So, only situation specific. This interferes with education or occupation or social communication of the individual. The duration of this disturbance, the selective mutism, should at least be a month for us to diagnose it. The failure to speak is not attributed to the lack of knowledge or comfort within the spoken language. So, let's not confuse it with anything related to speech. The disturbances is not explained by communication disorder. It does not occur exclusively during the course of autism spectrum or schizophrenia or psychotic disorder. So, if you see the signs and symptoms which are matching any of these diagnoses, then we cannot rule selective mutism as a different diagnosis. Some of the key pointers that you need to remember while taking history is the duration, the triggers, the onset, when did it start, how did it start, for how long has it been going. Few questions that you ask is, how is the mood of the child? How long has it been since they have noticed this behavior in the child? Any changes in their surroundings can identify or cause such behavior. Now, emotional and behavioral responses, to check that, you can ask, have there been any behavioral changes that you've noticed in the child of late? Have they been throwing any tantrums, any temper changes, any behavioral changes? Social isolation and withdrawal are also key factors to note here. The question may sound like, does he tend to cut off or avoid meeting people or friends? The presence of psychosocial stressors should also be ruled out. That can be marked fear or anxiety about a specific object or a situation, let's say example height. The phobic object or the object which is inducing this phobia or situation almost provokes immediate fear or anxiety. The phobic object or situation is avoided or endured with intense fear or anxiety. The fear or anxiety is also out of proportion with respect to the actual danger. Now coming to specific phobias. Specific phobias are a persistent fear or anxiety or avoidance for a minimum of 6 months. This has caused clinically significant distress or impairment in socio-occupational functioning or other important areas of functioning. This disturbance is not better explained by the symptoms of another disorder. The specifiers for you to rule out any specific phobias, it could be about an animal, a natural environment, blood injection injury, fear of blood, fear of injections, transfusion, fear of any other medical care, the fear of injury or situational, which could be about aeroplanes, elevators, enclosed spaces, and other situations that may lead to choking, vomiting in children, especially for example loud sounds or costumed characters. Specific phobia is a fear or anxiety in the presence of a specific situation or object. This is the phobic stimulus. This was defined by APA, American Psychiatric Association, in 2013. This fear or anxiety must be markedly stronger than the actual threat of the object or situation, such as the likelihood of being stuck on a well-maintained elevator, where the risk is almost negligible and yet you have the fear and anxiety. Certain key points to take into account when taking history to rule out specific phobias is again the duration, onset, triggers, since how long have they been experiencing the specifiers, when did it start, how can they identify a surrounding or object that initiates that response in them. Any crying tantrums, clinging behavior, freezing that can be seen in children, any panic attacks that we can see in adults, avoidance, anxious anticipation or distress in fearful situations. Due to this fear, do they avoid going out or being at places where that fearful object can be encountered? Marked socio-occupational dysfunction or impairment, and does the fear seem to interfere with their daily life? That is all for specific phobias. Moving on to social anxiety disorder. There is a marked fear or anxiety about one or more special situations in which the individual is exposed to possible scrutiny by others. The individual, they act in a way or show anxiety symptoms that will be negatively evaluated. The social situation always provokes fear or anxiety, and that also leads to their social isolation, which is their avoidance from that situation. The social situations are avoided or endured with intense fear or anxiety whenever they have to be. The anxiety is completely out of proportion to the actual threat that is posed in these social situations or are out of context in that socio-cultural aspect. The fear of anxiety and avoidance is persistent, typically lasting for about 6 months. It clinically causes significant distress or impairment in socio-occupational functioning or other important areas of life. The disturbance should also not be better explained by any other symptoms of any other disorder. Social anxiety disorder is also an ongoing fear or worry surrounding myriad social situations. It is one of the most common mental disorders with a lifetime prevalence rate of significantly greater than 10%. Certain key points that you need to keep in mind while taking history to elicit social anxiety disorder are that of any physical symptoms, the duration, triggers, onset, how long have we been feeling that, when did it start, any specific triggers or surroundings that initiate that response. The triggers could mostly be social situations. If they are losing focus on performance based activities such as academics or occupation, how has their mood been if it has been impacted by that anxiety? What are the kind of negative thoughts that they are having in these situations? Are there any thoughts that come up in their head when they have to go out or be in that specific situation? Let's understand that social anxiety disorder is one of the most prevalent disorders and one of the least diagnosed disorders. Every one of us on some level or the other face social anxiety. It could be for a presentation, it could be for a conference, it could be related to stage, which is stage anxiety, and it starts as soon as in childhood. So you'll see a lot of adults who are struggling with social anxiety. It's only in their adulthood that they're coming to realize that. But the symptoms or the distress can go way back into their childhood when you take that history and background. Coming next to panic disorder. A panic disorder is a recurrent, unexpected panic attack. A panic attack is an abrupt surge of intense fear or discomfort that reaches a peak within minutes, during which time 4 or more of the following symptoms could also be seen. Number 1, palpitations, which is racing heartbeat, sweating or perspiration, trembling or shaking, especially in the extremities of your hands and your feet, sensation of shortage of breath, you feel heavy while you're breathing. It could be accompanied with nausea, sometimes vomiting, chest pain or heaviness in chest or slight discomfort. Few more are the feeling of paralysis, like you are not able to move, you are in a freeze condition. Derealization, where you feel detached from your surroundings and even from yourself. Fear of losing control, and also sometimes fear of dying. Those are the symptoms that one feels when they have a panic attack. At least one of the attacks has been followed by 1 month or one or both of the following symptoms as the follows. Persistent concern or worry about an additional panic attack. Significant maladaptive changes in behavior related to the attacks. Points to remember while taking history. Again, the duration, the triggers, the onset, since how long have they been fearing that so and so would happen. When did it start? And can they identify a surrounding or an object that initiates that response? What according to them are the triggers, the social situations where this happens? How has this impacted their mood? If there are negative thoughts, then can you identify the thoughts associated with the triggers of the mood? Now, to understand panic disorder and differentiate it from an anxiety disorder. An anxiety attack is a one-off attack that happens and at a larger duration. And there the anticipation or the panic created for the next attack is not there. Whereas in panic disorder, where we have panic attacks, there is a constant anticipation as to when the next attack is going to happen. You would see that both an anxiety attack and a panic attack would have similar symptoms, but mostly in a panic attack, it would be of so much intensity that the individual might feel that they're about to die. Moving on to the next diagnosis, which is agoraphobia. There is a marked fear or anxiety about 2 or more of the following 5 situations as I'm going to lay out. It could be using public transport, being in open spaces, being in closed spaces, standing in a line or a crowd, or being outside of the home alone. The individual fears or avoids these situations. It always provokes fear and anxiety when they think about that. These situations are actively avoided and they require the presence of a companion to reduce that anxiety. The anxiety is out of proportion according to the actual threat which is posed in that social situation or in that socio-cultural context. The fear, anxiety and avoidance is persistent, typically lasting for about 6 months. Please keep note of all the durations which are varying in all the disorders. So for agoraphobia, it is that of 6 months. Agoraphobia causes clinically significant distress or impairment in socio-occupational functioning or any other important functioning areas of daily life. The disturbance is not better explained by symptoms of any other disorder. Please remember that you also have to rule out any comorbidity, because if there is comorbidity, the diagnosis changes. Certain key points to keep in mind while taking history: what are the physical symptoms, duration, triggers, onset, mood, any negative thoughts that are associated with that. Now, agoraphobia is also one of the most prevalent disorders and yet the most underdiagnosed ones. You would come across people who would shy away from going to crowded places such as theatre. They feel that what if there is a stampede? What if something happens? And how would all these people be able to exit? And what if something happens to me in that? Or let's say they've gone to a fair, maybe a book fair, maybe where you have the swings. The constant thought of open spaces and the anxiety associated with it is that it is going to be a crowded place. And if something were to happen which is uneventful, how would they possibly try to escape that situation? Next, we would like to come to generalized anxiety disorder, which, like I had mentioned, GAD. It is excessive anxiety and worry occurring more days than not for at least 6 months and about a number of events or activities, not just one, not just specific. Because if it were to be specific, then that would be ruled out as any specific phobia. The individual here, they find it difficult to control their worry. The anxiety or the worry are associated with 3 or more of the following symptoms. 1. Restlessness or feeling keyed up or on edge. 2. Being easily fatigued. 3. Difficulty concentrating or mind going completely blank. 4. Irritability. 5. Muscle tension. 6. Sleep disturbance. So understand that to rule out any or to make diagnosis of any disorder, the DSM criteria gives us anywhere from 6 to 9 pointers, and at least 4 to 5 should be present in order for us to diagnose. Generalized anxiety disorder is also where the anxiety is out of proportion than the actual threat and does not fit in the social situation or the socio-cultural context. The fear, anxiety and avoidance is persistent, typically lasting for about 6 months. It causes clinically significant distress or impairment in everyday functioning or socio-occupational functioning, and the disturbance should not be explained by symptoms of any other disorder. Key pointers to take in mind while taking history: the physical symptoms, the duration, triggers, onset, when did they first start experiencing that, how has it impacted their mood, the symptoms and the incidences specific to that, what have they been experiencing in terms of these symptoms, what are these specific triggers, any negative thoughts if at all present. That's all for this. Thank you.